Welcome to the anatomy and biomechanics of the knee joint complex. We'll start with the anatomy, and once you are oriented to the structures, we'll continue with the biomechanics. The knee joint complex is composed of three joints: the tibiofemoral, the patellofemoral, and the superior tibiofibular or superior tib-fib joint. The tibiofemoral joint is the articulation between the convex or male femoral condyles and the concave or female tibial condyles on the tibial plateau. The medial condyle on the femur, number 3, is longer antero-posteriorly than the lateral condyle. This will be relevant when we look at the screw-home mechanism of the knee in the biomechanics section. The adductor tubercle is number 1 on the medial femoral condyle. The trochlear or femoral groove is number 4. It is between the two condyles anteriorly, while the intercondylar fossa, number 8, is between the two condyles posteriorly. Moving to the tibia, the medial tibial condyle, number 2, is larger and longer antero-posteriorly. The intercondylar area of the tibia is called the intercondylar eminence and has the medial and lateral tibial spines, the numbers 13. Now that we have the bones, let's put them together to form the tibiofemoral joint. In standing, the normal alignment of this joint is approximately 5 to 10 degrees of valgus. If there is greater than 15 degrees valgus, the term genu valgus is used, what lay people would call knock-kneed. If there is less than 0 degrees valgus, genu varum exists, also known as bow-legged. As we continue to build the tibiofemoral joint, we will need to add articular cartilage to the femoral and tibial condyles. This hyaline cartilage is aneural and avascular, unlike the subchondral bone beneath it. The articular cartilage on the medial condyles can be up to 3 times thicker than the lateral condyles. Next, we will add to the tibial condyles asymmetrical wedges of fibrocartilage called menisci. Menisci are triangular in cross-section. They are thicker at the periphery and thin centrally. They end centrally at horns, the anterior and posterior horns. The medial meniscus is shaped like a C or a semicircle. It is wider posteriorly than anteriorly. It covers 50% of the medial articular surface of the tibia. Its anterior horn attaches anteriorly to the anterior cruciate ligament. The posterior horn attaches behind the intercondylar eminence and sits posterior to the posterior horn of the lateral meniscus. The periphery of the medial meniscus is attached to the joint capsule throughout its length. Fibers attaching the meniscus to the tibia are referred to as coronary ligaments. At its midpoint, the periphery of the medial meniscus is attached to the deep fibers of the medial collateral ligament. The lateral meniscus is shaped like an O or more circular. It is uniform anteriorly and posteriorly. The lateral meniscus covers 75% of the lateral articular surface of the tibia. The anterior horn attaches posterior to the anterior cruciate ligament. The posterior horn attaches anterior to the posterior cruciate ligament. Like the medial meniscus, the periphery of the meniscus is attached to the joint capsule throughout its length, except posterolaterally where it is crossed by the tendon of popliteus. There are connections between popliteus and the lateral meniscus. The coronary ligaments of the lateral meniscus are looser than the medial meniscus. There are no attachments of the lateral meniscus to the lateral collateral ligament. 70% of knees have a meniscofemoral ligament attaching to the lateral meniscus, which is believed to pull the lateral meniscus during weight-bearing flexion. The functions of the menisci are to increase joint stability by increasing the curvature of the tibia, resulting in increased joint congruence. As well, with compression, fluid seeps from the meniscus, providing lubrication. With its innervation, the meniscus has a role in joint proprioception. The menisci assist load transfer in weight bearing by increasing the effective weight-bearing surface area of the tibia and the femur, spreading the compressive load over a greater area. Finally, the menisci assist in shock absorption. There is 20% loss of absorption if the meniscus is lost. The menisci are highly innervated in their outer one-third and the anterior and posterior horns. There is less innervation as you move centrally. The outer edges are also fairly well vascularized, although this decreases with age. At age 18, 25 to 30% of the outer portions of the meniscus are vascularized, but only 10% by age 50. The anterior and posterior horns are well vascularized for life. Meniscal tears in vascularized zones possess the ability for repair. Now let's hold the tibia and the femur together with a joint or articular capsule lined by synovial membrane. This membrane also lines the suprapatellar bursa. The cruciate ligaments, although within the capsule, are extrasynovial as the membrane is reflected. The medial and lateral synovial folds may converge into the joint cavity to form a synovial plica. We'll look at this in the patellofemoral section. The posterior joint capsule attaches to the margins of the femoral condyles and intercondylar fossa. The posterior capsule attaches distally to posterior margins of tibial condyles and intercondylar fossa. It blends with the attachments for gastrocnemius and is centrally reinforced by the oblique popliteal ligament. A capsular sac separates the lateral meniscus from the tendon of popliteus. The medial joint capsule attaches to the medial tibial and femoral condyles just beyond the articular margins. Between the medial femoral condyle and medial meniscus, the capsule thickens to become the deep portion of the medial collateral ligament. The lateral joint capsule proximally attaches to the lateral femoral condyle above the popliteal tendon. The capsule descends over the popliteal tendon to the tibial condyle and head of the fibula. The lateral collateral ligament is separated from the deep fibers of the capsule by fat and neurovascular structures. The anterior joint capsule is insufficient. The true capsule ends at the patella, but blends with the suprapatellar bursa such that the knee joint cavity and bursa communicate. The capsule blends with the fibers of the expansions of vastus medialis and vastus lateralis to travel to the patella, patellar tendon, and tibial and femoral condyles to form the medial and lateral retinacula. Although the capsule holds the femur and tibia together, the knee requires reinforcement for stability. On the medial aspect, which is the lower figure of these two, there are a number of structures. Let's look at the MCL first. The medial collateral ligament is composed of superficial and deep fibers. Both superficial and deep fibers originate just below the adductor tubercle of the medial femoral condyle. The superficial fibers travel distally and slightly anteriorly to insert into the proximal medial shaft of the tibia, approximately 3 to 4 centimeters distal to the joint line, just inferior to the pes anserine insertion. The pes anserine bursa sits between the ligament and the tendons. The deep fibers travel into the meniscus and emerge to rejoin the superficial fibers. The deep fibers augment the stability of the medial meniscus. Both fibers function to limit valgus stress to the knee. The more anterior fibers are taut from 70 to 105 degrees of flexion, while the posterior fibers are more taut in extension. The posterior oblique ligament is sometimes called the oblique fibers of the MCL, but it is a distinct structure that supports the posteromedial corner of the knee. It arises from the adductor tubercle of the medial femoral condyle above the medial collateral ligament. It attaches to the tibia and semimembranosus, to the posteromedial joint capsule, and the medial meniscus. Other medial stabilizers include the fascial extensions of semimembranosus, vastus medialis, and the pes anserine tendons, which are sartorius, gracilis, and semitendinosus. Many people remember the saying, "Say grace before tea," to remember the order of these three tendons. The patellar retinaculum also provides medial stability. The lateral aspect of the knee is also stabilized by a number of structures. The lateral fibular collateral ligament is round and pencil-shaped. It runs from the lateral femoral condyle just posterior to the apex of the ridge between the origins of gastrocnemius and popliteus. The lateral collateral ligament travels inferior and posterior, finishing on the fibular head. The lateral collateral ligament does not attach to the capsule or meniscus, lying over popliteus at the joint line. It is easily palpated in the figure 4 sitting position, where the lateral malleolus rests on the opposite knee. The lateral collateral ligament primarily resists varus stress. The iliotibial band or tract inserts into Gerdy's tubercle on the lateral aspect of the proximal tibia. The ITB is taut throughout knee and hip range of motion. In extension, the iliotibial band sits anterior to the axis of rotation, while at 30 degrees it is over the axis of rotation, and beyond 30 degrees of flexion, the iliotibial band sits behind the axis of rotation, as well as behind the apex of the ridge of the lateral femoral condyle. Popliteus is a muscle that functions to produce internal rotation of the knee, particularly important during flexion from the extended position, helping to unlock the knee. Popliteus resists external rotation and may help bring the lateral meniscus posteriorly during knee flexion. The arcuate ligament is Y-shaped and runs from the fibular head to the lateral joint capsule, also to the posterior joint capsule. The popliteofibular ligament runs from the fibular head to popliteus at its muscle-tendon junction. It acts as a pulley to support popliteus and help reinforce the posterolateral corner, particularly from posterior translation of the tibial condyle, as occurs in combined extension external rotation forces. Finally, the fibellofibular ligament runs from the fibular head to the fibella, which is a sesamoid bone in the lateral head of the gastrocnemius. I particularly like that word when I play anatomical hangman because most people will guess patella instead of fibella. Next we move on to the anterior cruciate ligament, the most feared ligament injury by many athletes. It is number 5 in this picture. The anterior cruciate ligament originates from the anterior aspect of the tibial plateau, just medial to the attachment of the lateral meniscus. It runs superiorly, posteriorly, and laterally and inserts into the posterior aspect of the medial surface of the lateral femoral condyle. It is generally thought to be made up of fascicles that form two bands with some intermediate fibers. The bands wind on themselves. The anteromedial band is relatively more taut in flexion, less so in extension. The posterolateral band is relatively more taut in extension and less in flexion. The intermediate fibers ensure that some portion is taut throughout the range of motion. The anterior cruciate ligament is the primary restraint to anterior tibial translation, but it is also a secondary restraint to valgus and varus forces. It is also a secondary restraint to external tibial rotation when the knee is flexed. The anterior cruciate ligament has its own arterial supply, and when it ruptures, a hemarthrosis, which is a hot, swollen, bloody joint, may occur. The posterior ligament stabilizers include the posterior cruciate ligament and the oblique popliteal ligament. The posterior cruciate ligament is labeled number 3 in this picture. The tibial attachment is to the posterior aspect of the intercondylar region, as well as the posterior aspect of the tibia 1 centimeter below the tibial plateau. The femoral attachment is to the lateral aspect of the medial femoral condyle. The PCL blends with the posterior joint capsule and is divided as well into two bands: anterolateral, that is more taut in flexion, and posteromedial, that is more taut in extension. The PCL is the primary restraint to posterior tibial translation, and this strain increases as the angle of flexion increases, greatest at 90 degrees. The PCL also provides a secondary restraint to external tibial rotation. The muscles that flex the knee and translate the tibia posteriorly, such as the hamstrings and the gastrocs, increase the strain on the posterior cruciate ligament, while the pull of the quadriceps decreases the strain. The oblique popliteal ligament runs from the posteromedial capsule as well as fibrous expansions of semimembranosus. It crosses the posterior aspect of the knee, finishing at the central part of the joint capsule, meeting the medial arm of the arcuate ligament and into the lateral femoral condyle. It resists extension and posterior tibial translation. There are numerous bursae of the knee. Anteriorly, there are 4: the prepatellar bursa between the patella and the skin, the deep infrapatellar bursa between tibia and patellar tendon, the subcutaneous infrapatellar bursa between the tibial tuberosity and the skin, and the suprapatellar bursa. Laterally, there's also 4 bursae. One is between the lateral head of gastrocnemius and the joint capsule. The next is between the lateral collateral ligament and the tendon of biceps femoris. The third is between the lateral collateral ligament and the tendon of popliteus. And finally, a bursa between the tendon of popliteus and the lateral femoral condyle, which is usually an extension of the joint capsule. Medially, there's also 4, the first being between the medial head of the gastrocnemius and semimembranosus. There's another between the medial head of gastrocnemius and the capsule. The third is between the medial collateral ligament and the tendons of gracilis sartorius and semitendinosus, the pes anserine, meaning the goose's foot. Deep to the medial collateral ligament, separating it from the femur, the capsule, and the meniscus, or semimembranosus, is the 4th medial bursa. The posterior aspect has continuations of the medial and lateral bursae. A Baker's cyst, or a popliteal cyst, is typically an inflamed gastrocnemius semimembranosus bursa that communicates with the joint. Now let's move on to the muscles that move and help control movement at the tibiofemoral joint. The primary flexors are the hamstrings, composed of semitendinosus, semimembranosus, and the short and long head of biceps femoris. The accessory flexors include gastrocnemius, popliteus, gracilis, sartorius, and plantaris. These muscles not only flex the tibiofemoral joint, but restrict and control extension of the tibiofemoral joint. The extensors of the tibiofemoral joint are primarily the quadriceps with some help from tensor fascia lata, and these muscles will restrict flexion. The medial rotators of the tibia, when the tibia is flexed at the femur, are semitendinosus, semimembranosus, gracilis, and sartorius. Popliteus is also an internal rotator of the tibia, but when the knee is extended. Popliteus is a triangular-shaped muscle that you can see on the right-hand picture on the inferior aspect of the knee. It has a proximal tendinous origin from 3 points: the lateral femoral condyle, the fibula, and the posterior horn and posterior aspect of the lateral meniscus. The muscle belly inserts into the posteromedial aspect of the proximal tibial shaft. Popliteus is the only muscle capable of internally rotating an extended knee, and it initiates reversal of the screw-home mechanism during initial flexion of the extended knee in gait. The lateral rotators of the tibiofemoral joint include the biceps femoris and the tensor fascia lata. These muscles restrict internal rotation. The innervation of the tibiofemoral joint segmentally includes from L2 all the way to S3, but L3 is the predominant contributor. The nerves which contribute to the knee joint are the obturator nerve, the femoral nerve, the tibial nerve, and the common peroneal nerve. The cutaneous distribution, the medial knee is innervated. The skin over the medial knee is innervated by the medial cutaneous nerve of the thigh, as well as the saphenous nerve. The saphenous nerve also provides innervation to the skin over the anterior aspect of the knee. The posterior cutaneous nerve of the thigh innervates the skin over the posterior knee, while the lateral cutaneous nerve of the calf and leg innervates the skin over the lateral knee. The femoral nerve gives articular branches to supply the anteromedial capsule and ligaments, the anterolateral capsule and ligaments, the superolateral capsule, the infrapatellar fat pad, and the patellar tendon. The saphenous nerve has articular branches which supply the infromedial capsule and the patellar tendon. The common peroneal nerve gives articular branches which supply the infralateral capsule and the lateral collateral ligament and the anterolateral capsule at the joint line. As you can see in this slide, the knee is well vascularized with numerous contributors to the arterial anastomosis. These include the descending genicular artery, which is a branch from the femoral artery, the superior, middle, and inferior genicular arteries, which are branches of the popliteal artery, the anterior and posterior recurrent branches of the anterior tibial artery, the circumflex fibular artery, and finally the descending branch of the lateral circumflex femoral artery. Now that we have looked at the structures of the tibiofemoral joint, let's see how they work together to provide stability. The primary stabilizer is often obvious, but the secondary restraints need to be recognized so they can be assessed and, if need be, treated. Anterior stability is primarily restrained by the anterior cruciate ligament, with secondary restraints being the medial collateral ligament, lateral collateral ligament, iliotibial band, anterior horns of the menisci, the joint capsule, and the hamstring muscles. The primary restraint for posterior stability is the posterior cruciate ligament, with secondary restraints being the following ligaments: the MCL, lateral collateral, fibellofibular, popliteofibular, oblique popliteal, and posterior oblique ligament. The popliteus muscle and the joint capsule and the posterior horns of the meniscus are secondary restraints as well for posterior stability. Valgus stability, the primary restraint, is the medial collateral ligament and the posterior oblique ligament. The secondary restraints are the ACL, PCL, joint capsule, meniscus and coronary ligaments, gracilis and sartorius, medial hamstrings, and medial head of gastrocnemius. Varus stability, the primary restraints are the lateral collateral ligament and the iliotibial band. The secondary restraints include popliteus and the following ligaments: the arcuate, fibellofibular, popliteofibular, ACL, PCL, and coronary ligaments, along with the joint capsule, the meniscus, biceps femoris, the lateral head of gastrocnemius. Anteromedial stability is provided by the ACL, the MCL, the anterior horn of the medial meniscus, the anteromedial joint capsule, and the pes anserine group. Anterolateral stability is provided again by the ACL, but this time with the iliotibial band and the anterior horn of the lateral meniscus, as well as the anterolateral joint capsule. Posteromedial stability comes from the posterior cruciate ligament, along with the posterior oblique ligament, semimembranosus, the oblique popliteal ligament, the posterior horn of the medial meniscus, and the posteromedial joint capsule. And finally, the posterolateral stability will be the posterior cruciate ligament, popliteus, and the following ligaments: the arcuate, fibellofibular, popliteofibular, oblique popliteal, and posterior oblique ligament, as well as the posterior horn of the lateral meniscus and the posterolateral joint capsule. Now we'll move on to the patellofemoral joint. This is the articulation between the trochlear or femoral groove on the anterior aspect of the femur, number 4 on the picture, and the facets on the posterior aspect of the patella, numbers 3, 5, 6, and 7. In the picture of the patella labeled D, the superior facets, numbers 5, articulate with the femur in flexion. The inferior facets, number 6, are in contact during extension, but not full extension. The odd facet, number 7, is most medial and articulates during end range flexion, such as squatting or kneeling. Just inferior to the articular surface is the area for the infrapatellar fat pad, number 8. Below this is the attachment of the patellar tendon, number 9. The patella is the largest sesamoid bone in the body. It is embedded in the quadriceps tendon. The superior aspect of the patella is called the base, and the inferior tip is the apex. For surface anatomy, the apex is only slightly proximal to the tibiofemoral joint line in standing, unless the patella sits high, which is called patella alta, or low, where the term is patella baja. The patella increases the mechanical advantage of the quadriceps and the contraction force by up to 30%. The lateral condyle of the femur is usually higher than the medial. When this is not as well developed, there can be an increased incidence of patellar dislocation laterally. The articular cartilage of the patellofemoral joint is the thickest in the body, being approximately 7 millimeters thick in the center of the patella. The articular facets exist that are quite varied from one individual to another. All patellae have a vertical ridge that descends, then veers off. 60% of the time it veers medially, as it does in this picture, while 40% of the time it remains vertical. 80% have a second vertical ridge on the medial facet, creating the odd facet. The articular cartilage of the patella is more permeable and pliable than other cartilage in the body. The patellar capsule extends from the medial and lateral tibial and femoral condyles. As it approaches the patella, it blends with the fibrous expansions of vastus lateralis and medialis. The capsule does not pass over or proximal to the patella. It attaches to the patella and the patellar tendon. Synovium lines the inner surface of the capsule, but is separated from the patellar tendon by the infrapatellar fat pad. The bursa of the patellofemoral joint include the prepatellar bursa, which overlies the patella, the deep infrapatellar bursa, which lies behind the tibia and the patellar tendon, and the subcutaneous infrapatellar bursa between the tibial tubercle and the skin. Capsule fibers join the following structures to form the lateral retinaculum: fibrous expansion of vastus lateralis, aponeurotic and superficial fibers from the iliotibial band, lateral patellofemoral ligament, the iliopatellar band of the iliotibial band, and the lateral patellotibial ligament. Historically, the surgeons have released this structure, believing that the patella moved too far laterally. It has been shown that the patella doesn't move too far laterally, but instead, due to lack of control of the femoral abductors and lateral rotators, with flexion frequently the femur moves too far medially. The medial retinaculum is formed from the capsule fibers fusing with the meniscopatellar ligament, the medial patellotibial ligament, the fibrous expansion of VMO, and the medial patellar ligament. The patellar tendon, which is below the patella, is frequently referred to as the patellar ligament, as it does connect bone to bone, but it is a tensile structure histologically, and it is a tendon that transmits the force of the quadriceps muscle. It originates at the inferior pole or apex of the patella and inserts into the tibial tubercle. It is 5 to 6 centimeters long and 3 centimeters wide. It receives vascular supply from nearby arteries as well as the fat pad. The quadriceps tendon is above the patella. It inserts into the patella in 3 layers. The superficial layer is from rectus femoris, the intermediate layer from vastus lateralis and vastus medialis, and the deep layer is vastus intermedius. The fat pad sits behind the patellar tendon and is richly innervated. It is extrasynovial but intracapsular. It is attached to the menisci. A plica is any fibrous band of tissue spanning the knee joint. Plicae are remnants of the membrane that once separated the various components of the knee. A normal plica is a soft, pliant, highly elastic tissue. During flexion and extension, it moves back and forth over the femoral condyles. Inflammation may result in an inelastic, fibrous band that may lead to patellofemoral dysfunction. The articular supply of the patellofemoral joint, like the tibiofemoral joint, has segmental innervation from L2 to S3, but is primarily an L3 joint. There are contributions from the obturator nerve, the femoral nerve, the tibial nerve, and the common peroneal nerve that form a fine mesh that accompany the small vascular vessels over the patella. The cutaneous supply of the medial aspect of the patellofemoral joint is from the medial femoral cutaneous nerve, as well as a branch of the nerve to vastus medialis, and an anterior branch of the obturator nerve. Laterally, the lateral retinacular nerve, which is a branch off the sciatic nerve, and the lateral femoral cutaneous nerve supply the skin over the patellofemoral joint. The vascular supply of the patellofemoral joint is that the patella is very well vascularized. A major vessel enters the patella from each quadrant: the superior medial geniculate artery, the inferior medial geniculate artery, the superior lateral geniculate artery, and the inferior lateral geniculate artery. Smaller vessels also enter via the superior and inferior poles of the patella. An anastomosis forms from the geniculate arteries that perforate the anterior aspect of the patella. Given that the patella is embedded in the quadriceps muscle, we will look at it in greater detail. But don't forget about articularis genu, which is a muscle that inserts into the suprapatellar bursa and supports it proximally. The articularis genu prevents the bursa from being caught behind the patella as the knee extends. Now back to the four heads of the quadriceps muscle. The vastus medialis portion is sectioned into two. The vastus medialis oblique, which has a line of pull 50 to 55 degrees from the long axis of the femur. The vastus medialis obliquus cannot extend the knee, but instead centers the patella medially. It originates from adductor magnus and has its own separate innervation, a branch of the femoral nerve. A 50% reduction in VMO activity may result in lateral displacement of the patella of 5 millimeters. Vastus medialis longus has a line of pull 15 to 18 degrees from the long axis of the femur, and therefore is able to extend the knee with the rest of the quadriceps. The vastus lateralis has a line of pull of 15 to 40 degrees from the long axis of the femur laterally. The rectus femoris is the only quadriceps muscle to cross both the knee as well as the hip. The hip position affects its ability to generate tension. The line of pull is 5 degrees medial of the long axis of the femur. The vastus intermedius has a line of pull that is in line with the long axis of the femur. With no bony attachments, what keeps the patella in the trochlear groove? Well, actually, at full extension, the patella does not sit in the trochlea, but rather above it, and is vulnerable here to subluxation and dislocation. At approximately 20 degrees of knee flexion, the patella enters into the trochlear groove and is provided better articular stability. Lateral stability is affected by the depth of the groove, which is enhanced by the high lateral condyle. Soft tissue support offered to the patellofemoral joint includes the medial retinaculum, the medial patellofemoral ligament, the lateral retinaculum, the lateral patellofemoral ligament, the iliopatellar band of the iliotibial band, the patellar tendon, and the quadriceps tendon. There is also dynamic control of the patella via the vastus medialis obliquus, vastus medialis, vastus lateralis, rectus femoris, vastus intermedius, and articularis genu. And the final joint of the knee complex is the superior tibiofibular joint. This is the articulation between the proximal ends of the tibia and the fibula. The articular surface on the tibia, number 15 on the right bone, is on the posterior inferior surface of the lateral tibial condyle. It is a small circular facet that is usually planar. This facet faces posterior, inferior, and lateral to match the facet on the fibula. The proximal end of the fibula is enlarged anteriorly, posteriorly, and laterally. The styloid process, number 3 on this picture, projects up from the posterolateral aspect. The joint surface, number 2 on this picture, is usually circular and planar and faces medial, anterior, and superior. The role of fibular function has been described as dissipation of torsional stresses applied at the ankle, dissipation of lateral tibial bending forces, and absorption of tensile loads. Compressive loads that are transmitted by the fibular are much greater if the ankle is dorsiflexed or everted. The angle of inclination of the fibular joint surface varies. A horizontal surface is larger and possesses greater range of motion, while the oblique surfaces have a smaller surface area and less range of motion. The hyaline cartilage covers the joint surfaces of the superior tib-fib joint. The joint capsule is specific to the joint, attaching to the margins of the rims of the fibular facets. The capsule is thicker anteriorly than posteriorly. The capsule is reinforced by an anterior superior tib-fib ligament and a posterior superior tib-fib ligament. The interosseous membrane connects the bones below this joint. The fibula also provides attachment to the lateral collateral ligament, the popliteofibular ligament, the arcuate ligament, and the fibellofibular ligament. The segmental supply of the superior tib-fib joint is L4 to S3. The articular branches are from the common perineal nerve and the nerve to popliteus. The common perineal nerve passes over the neck of the fibula and may be affected by movements of the fibula or injuries to the joint. The vascular supply of the superior tib-fib joint is from the anterior and posterior tibial recurrent rami of the anterior tibial artery and the circumflex fibular artery. Now that you are oriented to the anatomy of the knee joint complex, let's look at the movements at these joints. The tibiofemoral joint is a synovial joint. It is compound as it has more than 2 articulating surfaces within the joint capsule. It is complex due to the presence of the menisci, which are intra-articular discs. It is a modified ovoid, which would make you suspect that it would have 2 swings for its degrees of freedom. But instead, due to the bicondylar structure, this modified ovoid has the ability to spin around its mechanical axis. Therefore, when looking at the osteokinematics of the tibiofemoral joint, there are 2 degrees of freedom, but only 1 is an impure swing. This movement is flexion and extension, which is an impure swing about a transverse axis in a sagittal plane. It has 18 degrees of conjunct lateral rotation in the final 30 degrees of extension, especially the final 5 degrees. The internal and external rotation is the 2nd degree of freedom. It is a spin about a vertical axis in a frontal or coronal plane. What are the accessory glides at the joint surfaces that are associated with the physiological movements? These are called the arthrokinematics. Well, if the femur is fixed, as during non-weight-bearing open kinetic chain exercises, the accessory glide of flexion is a posterior glide of the tibia on the femur, and the accessory glide of extension is an anterior glide of the tibia on the femur. But if the tibia is fixed, as during weight-bearing closed kinetic chain exercises, such as squats, and coming downstairs, during flexion, the femur glides anteriorly on the tibia, and during extension, the femur glides posteriorly on the tibia. The arthrokinematics of rotation, if we look at lateral rotation first, there's an anterior glide of the medial tibial condyle and a posterior glide of the lateral tibial condyle on the femur. With internal rotation of the tibia, there is a posterior glide of the medial tibial condyle and an anterior glide of the lateral tibial condyle on the femur. During extension from a flexed position, the lateral tibial compartment, which is deeper and smaller than the medial tibial compartment, approaches congruency with the lateral femoral compartment, which is also smaller and has a shorter radius than the medial femoral compartment. When the knee is positioned in about 30 degrees of flexion, at this point the articular surfaces result in internal femoral rotation. The resulting conjunct relative external rotation of the tibia during terminal extension is termed the screw-home mechanism. This fully extended position with lateral rotation is the close-packed position of the tibiofemoral joint with maximum articular congruency and joint stability. Reversal of the screw-home mechanism may be termed unlocking. Contraction of the popliteus muscle is required to initiate femoral external rotation or tibial internal rotation against gravity. The other movement, the internal and external rotation that occurred at the tibiofemoral joint, is in greater degrees of flexion. In greater than 30 degrees of knee flexion, there's a total of 70 degrees of rotation, 45 degrees of which is external rotation, and 25 degrees is internal rotation. As the knee becomes less flexed and is only 5 degrees flexed, there's 33 degrees of total rotation, 2/3 of it being external rotation, and 1/3 being internal rotation. When the knee is fully extended, no rotation is permitted. The patellofemoral joint is also a synovial joint that is compound. Its articular surfaces are an unmodified cellar, but functionally it operates in a triplanar arc termed tracking, which occurs during knee flexion and extension. The osteokinematics, which is the bone in space, the patella moves superomedially during extension, as seen in picture E, and inferolaterally during flexion, as in picture F. And the arthrokinematics are fairly simple, as they follow the same direction. The superomedial movement in extension goes along with a superomedial glide of the patella on the femur, while the movement of flexion, requiring the patella to move inferolateral, also requires an inferolateral glide. In full extension to 15 degrees of flexion, the patellar position is medial and superior to the trochlear groove with no articular contact. In the position of 15 to 90 degrees of flexion, the patella enters the trochlear groove and is displaced further medially. The articular contact on the lateral and medial facet progresses from distal to proximal. In the picture D, it's from facets 6 to 5. Patellofemoral congruency increases with progressive degrees of flexion. Beyond 90 degrees, the patella moves laterally to rest superficial to the lateral femoral condyle in full flexion, and articular contact is made on the proximal parts of the lateral facets and medial facets, as well as the odd facet. With increasing flexion, the proximal quadriceps tendon articulates with the trochlear groove and reduces significantly the compression stress taken by the patellofemoral joint. The superior tib-fib joint is a synovial joint with planar joint surfaces. Due to a lack of research and wide variability in the anatomy of this joint, the osteokinematics and arthrokinematics have not been definitively established. It appears that during the body torque test in standing, with weight-bearing internal rotation of the tibia, the fibular head moves posterior relative to the tibia. With weight-bearing external rotation of the tibia, the fibular head moves anteriorly relative to the tibia. Most authors agree that there can be up to 3 movements that occur in the relationship between the tibia and the fibula. One movement is anterior-posterior, a second movement is superior-inferior, and a third movement is rotation. These motions occur all at the same time and are dependent on knee and foot position. Upon dorsiflexion, due to the talus width, the malleoli may slightly separate and a superior and posterior movement of the fibula may occur at the superior tib-fib joint. And this concludes the anatomy and biomechanics of the knee joint complex.